Well, good afternoon, everyone. Welcome back to National Conference. I'm in charge of housekeeping at the moment, so I'll just run through my various responsibilities. First of all, and this is not housekeeping, this is genuine thanks to our platinum sponsor, Allocate. I'd like to thank the Leadership Development Dinner sponsor, Avant, for their support in enabling the former Prime Minister, the Honourable Julia Gillard, to attend as guest speaker for the dinner. I'd like to thank the Gala dinner sponsor, AMA's corporate partner, OnePath, and our communications sponsor, AMA's corporate partner, Amex. And thank you to the many other conference sponsors, Decision Assist, FM Practice Solutions, the National Health and Medical Research Council, Up to Date, AMP, Hertz, and the Sunshine Coast Hospital and Health Service from Queensland Health. Next, I'd like to explain the Wi-Fi, and listen carefully. Wi-Fi has been provided for all delegates at the conference. The password is DR Portal. It'd be good if it came up on a screen somewhere. DR Portal 2015, all one word. So Dr. Portal, all one word. The password is not case sensitive. Please let the conference team know if you need any help with this. Doesn't work? Okay, we've got somebody looking into this. The next thing I'm going to explain is the next question and answer system. If you want to direct questions to the chair during the plenary sessions, go to, on your device, visit natcon, natcon.ama.com.au. Click on the plenary session you're attending, that's under Programs, and enter your question in the field indicated at the bottom of the page and click Save. Your question will be visible to all delegates. The chair will then direct the question to the speakers, and this system is only available during the plenary session and when the chair announces the session is open for questions. And there is a leaflet, for you to refer to on this matter. There's power boards at the end of all the rows of seats, so you can charge your device. Next, so there we are, we've got some instructions on the screen as well. Next, can I remind you that the CPD sessions attract RACGP and ACRIM points. And there's feedback sessions forms for all of the sessions. To complete your CPD feedback form, again you go to natcon.ama.com.au, click on the plenary session you're attending under Program, and go to the bottom of the page and you'll see the link to the feedback form. To have your points automatically added into your profile in the AMA's new CPD tracker, can you register please at Dr. Portal Online, and Annette and Paul at the CPD booth are very happy to help you sign up. Next, registrations for the soapbox session. This is Sunday morning. Could you please let Nadine over here at the minutes table know that you would like to speak at that session? Late registrations will be taken on Sunday morning, but we'll give priority to those who've registered first. So as soon as you know that that is something you want to participate in, could you please let us know so we can plan for time. And lastly, for the tweeters, the conference Twitter hashtag is #AMANC15. Now, have you got your voting cards ready for the next items of business? Okay, so the first item of business is the notice of this conference. The notice of the 2015 National Conference was circulated in the publication The Medical Journal of Australia on the 6th of April 2015. I now move that the notice of the 2015 National Conference of AMA Limited be taken as read, and I now put the motion by a show of voting cards. Those in favour? Against? Thank you. The motion is carried. We now move to the delegates. In accordance with Standing Order 5 of National Conference Standing Orders, no business may be transacted unless at least one half of the number of delegates eligible to attend is present, or if that is not a whole number, the next highest whole number of delegates. I note that today a latest issue of delegates has been circulated with a list of 156 delegates appointed in accordance with Clause 16 of the Constitution. I now move that the list of delegates present be noted for the purposes of accreditation of National Conference delegates. I now put the motion by a show of voting cards. Those in favour? Those against? Thank you. The motion is carried. Our next item of business is the acceptance of the National Conference Standing Orders. The National Conference Standing Orders have been circulated in your conference handbook, can be found on page 21. In accordance with the Standing Order 4.3 of National Conference, I now move that National Conference Standing Orders as circulated be adopted, and I put the motion by a show of voting cards. Those in favour? Those against? And the motion is carried. Could I ask you now to turn to page 25 in your handbook of the minutes section? And I would like now to discuss the National Conference minutes from 2014. I now move that the minutes of the 2014 National Conference be taken as read, and I put the motion by a show of voting cards. Those in favour? Those against? And the motion is carried. Matters arising and outcomes from the 2014 National Conference. In relation to the 2014 National Conference, there were 3 motions passed. Please find a brief report on the outcomes in the conference handbook on page 37. Are there any other matters arising directly from the minutes of the 2014 National Conference that any delegate wishes to raise at this point? Yes, Dr. Highcaller.
Madam Chair, thank you very much. It may sound a bit petulant to raise this, but when I was a delegate last year, I was actually chair of the World Membership Association.
Yes.
I think that won't happen ever again. I'd like to know
Ye-
sort of committing to that, particularly for the role that I've had as overseeing an observer in the last 20
Yes.
It's an honour that I've had the World Membership Association for 4 years in a row.
Yes.
Shall we say it again, or can you hear me?
No, of course, Makesha, we understood that the list of delegates was not in the minutes, but we'll fix that.
Thank you.
Thank you. Okay. All right, thank you. We'll now turn to the urgency motions. Okay, we have 2 urgency motions that have been received by 1 p.m. today. The first is moved by Mr. James Lawler, AMSA President, seconded by Dr. Michael Gannon, and who is going to talk to this motion? James? Thank you.
Hi everyone, my name is James Lawler. I'm the President of the Australian Medical Students Association this year. I'd like to thank the AMA for all the work they do for AMSA in supporting medical students, particularly me. My medical student peers are up the back there. Put your hands up, guys. So feel free to say hi to them throughout the conference. They're eager to learn about the AMA, as am I. I've been told not to address you as to the merits of this motion, but to address why this motion is urgent. The reason is simple, is that 5 weeks ago when motions were due for National Conference, there was no new medical school. 5 weeks ago, I thought the government better understood the problems that are being faced for medical trainees and graduating medical students, but it's clear they don't. I thought 5 weeks ago that if you need to cut $57 billion from public hospitals, then you don't have $20 million for a new medical school. And I thought that if Brian Aller sent a letter directly to the Health Minister articulating all the reasons why a new medical school was a bad idea, then no government, especially a reform government looking to listen to the profession, would commit to a new medical school. But it's clear they have. I thank the AMA for their strong support in opposing this new medical school. It's helped me, it's helped AMSA, and it's put faith in my medical student members that the doctors, the AMA and their future supports them in getting jobs and getting good quality training places to serve this community. So that's the motion I've put to you. I move that this above motion be debated as a matter of urgency. This motion has been seconded by AMA WA President Michael Gannon.
So, the question is, do you accept this as an urgency motion? We'll vote by showing cards. Those in favour? And those against? So the motion is accepted, and this motion will be debated in the session on Saturday afternoon at the conclusion of the President's Award presentation at 4 o'clock. Second urgency motion. Moved by Dr. Paul Bowett, seconded by Dr. Andrew Pesher. And Paul, you'll speak to it in the 2 minutes allocated. Thank you.
Thank you. This motion is urgent because the existing Federal Council policy relating to asylum seekers was written in 2011, a very strong document. Since then, there have been changes in government policy, which have been backdated to July 19th, 2013 in law. And we've been seeing increasingly the effects of this particular law, and perhaps urgently we're seeing the effects of this law in the press and in the media on a regular basis, and I think it's very urgent that we address this. So in February we saw the Human Rights Commissioner's report, Triggs. We also saw the Moss independent report, both of which highlight the problems of living in Nauru. As recently as Tuesday's Sydney Morning Herald, the headlines were the Department of Immigration and Border Control admits to being investigated by the Child Sexual Abuse Commission, and this relates specifically to sexual abuse on children on Nauru. A few weeks ago, Professor David Isaacs, on his editorial in the Journal of Paediatrics and Child Health, spoke of his recent visit to Nauru. He finished his commentary by saying, "Mandatory detention is immoral, but detention on Nauru is an abomination, and paediatricians should protest long and loud until it is ended." More recently, still 10 days ago, the Australian Paediatric Society issued a communique from its annual meeting. Amongst other things, the Australian Paediatric Society feels strongly that children and their families should be released from situations of proven harm and abuse in Australian-run detention centres and not transferred to foreign facilities where harm is likely to occur. I'm seeing these children and their families in my rooms, and my staff are seeing them on a weekly basis at the Royal Darwin Hospital. We are seeing sustained, ongoing, permanent damage to these children and their families. It's urgent that the peak body in Australia, the AMA, debate this motion in the absence of a notice. Thank you.
Thank you, Paul. Do you accept this as an urgency motion? We'll vote by a show of cards. Those in favour? Those against? One. Thank you. The motion is carried, and this urgency motion also will be dealt with in the session on Saturday afternoon. Okay, well, that concludes those proceedings, and we'll turn now to our first policy session.
Madam Chair,
Yes.
I would like to move the minutes of the 2014 annual general meeting be approved.
All right. Did I do everything except that?
That's right, the annual general meeting is adopted
At the end. Yes. So, Anne, do you want to speak to that?
I'm not sure if I do have volume. The annual general meeting itself will consider the minutes of the last annual general meetings. That'll be this afternoon at 4:10.
Yeah.
This is the proceedings of conferences compared with the proceedings of the annual general meeting.
All right. So, I'll proceed now to introduce the first policy session, and the chair of that session, Dr. Brian Morton. The session is called Funding Quality General Practice. Is it time for a change? Dr. Brian Morton has been an AMA Federal Counsellor since 2006 and is in his third term as Chair of AMA Council of General Practice. He served as President of the AMA New South Wales from 2008 till 10 and has been awarded a member in the General Division of the Order of Australia for significant service to medicine as a general practitioner. I invite Dr. Morton to the lectern.
Thank you, Madam Chair. Good afternoon, everyone. Our first policy session, funding of quality general practice. Is it time for a change? It's really important that we actually have an open mind and not a closed past history mind. I'll move so that I stand and respect you. There are a number of challenges facing general practice now into the future. The challenges include the ageing population and the increasing burden of chronic conditions and how that is increasing the complexity of care provision. A workforce that is seeking a greater work-life balance and a changing work environment that has shifted from the solo practitioner to the multidisciplinary team. Increasing expectations from patients. Ensuring value from health expenditure through effective and efficient care. Currently, fee-for-service is the primary funding mechanism for general practice. But in the context of the above challenges, there are some who believe we need to reform GP funding structures. Back in 2009, the National Health and Hospital Reform Commission suggested that fee-for-service may not be the best funding model for encouraging better continuity and coordination of care. They suggested that primary care funding into the future should involve a mixture of payments to fund not only comprehensive care, but reward better health outcomes. Is this the way forward? The government has recently announced a review of the Medicare benefits schedule and the establishment of a primary healthcare advisory group, and this is certainly open to suggestions. Today we'll discuss whether or not it is time for a change. Does fee-for-service still have a role as the primary source of funding for quality general practice? Is fee-for-service still meeting the needs of our patients? Do we need evolution, or perhaps some would say revolution? Remember, you can use the online question system to submit questions at any time during the session, and a draft motion at the end of the session will be considered, and that is actually on the table in front of you. We're actually fortunate today to have former AMA President, Dr. Steve Hambleton, to lead the discussion. He will be leading the Primary Healthcare Advisory Group. Steve is also the chair of the National eHealth Transition Authority and is committed to supporting our high-quality health system and ensuring it has a sustainable future. Steve will be sharing with us the objectives of the Primary Healthcare Advisory Group. I'd like you to welcome Steve Hamilton.
Thank you very much, Brian, and thank you very much, colleagues, for welcoming me back here today. It's an absolute pleasure to be here and to listen to your President talk about the achievements over the last year. And certainly, as I said in the Australian newspaper recently, the government is in no doubt what the AMA thinks, so we're still out there with our message. Look, I've been asked by the Minister to actually chair the Primary Healthcare Advisory Group. Originally, I was actually going to speak to you about funding models and be part of the panel, but it probably is a bit inappropriate seeing that I'm going to be the chair of that group. So Brian's kindly let me have a few minutes at the beginning of this meeting so that so I can actually benefit from the discussions here today. You'll see, if I press the button, and can someone move to the next slide? The last one, that's good. All right, you heard from the Minister this morning about what the Primary Healthcare Advisory Group's broad focus is going to be, and it is fairly narrow. We're looking at chronic and complex care. The Medicare Benefits Schedule review is the whole of the schedule. Now, that review is actually going to take a lot longer. It's going to take maybe a couple of years to come with its recommendations, and it's going to engage with the profession. My Primary Healthcare Advisory Group is intended to report at the end of this year, November 2015, and make some recommendations prior to the budget cycle. So it's going to be a very big challenge. But there's been a lot of work done in chronic disease management and planning. The AMA itself, the AMA Council of General Practice has come forward with a number of recommendations in the past. The College of GPs has currently got a consultation model going, which is actually timely. And I'm going to try and put together a senior group of people who can engage with the profession so we can actually talk to you and talk to other members of the profession in different areas about the sorts of things that we might be thinking of in the future. It is about better care for people with chronic and complex disease. We are going to look at innovative care and funding models. We want to better recognise and treat mental health conditions, given the poor recognition of that so far and based on the mental health reports that we've seen. And in particular, at the interface between hospital care and primary care. That's a very important interface where we know there is more efficient spending that can happen. We are certainly going to try to benefit from any international investigations and recommendations that are out there. I actually said to my group in our preliminary planning that with my AMA hat on, I would have said Australia goes overseas and finds systems that don't work and then bring them here. But I think we've got to do exactly the opposite. Go overseas, have a look at what's working, what is good for patients, how do we adapt that to the Australian environment. That doesn't mean we're necessarily going to throw out the current system, but we do need to build on it, build with it, do things that are actually capable of being implemented in this country. And so these are the sorts of things we'll be looking at. What we do as clinicians one-to-one with our patients is medical care, and collective medical care is population health. So we do need to actually measure and be able to understand the benefits that general practice provides, and at the moment it's hard to see those benefits and hard to collect them. So that may actually signal that we're going to start thinking about how we collect the data. Cost is always a problem when you put costs on a slide. I can assure you, and I can assure you from the private conversations I've had with the Minister and the terms of reference that I've got, that this is not about cost saving. In fact, I've argued with the department that we may find we want to spend more in this particular group to try to have a net cost saving because we do things more efficiently. And I haven't found any pushback at this point. We certainly want to improve the consumer engagement in their care. And if you read some of the international literature, we can actually get good doctors doing things a little better. But if we actually get the patients engaged and they change their behaviour, that can significantly change their trajectory. So what are the features of a high-performing healthcare system? As I said, patient engagement. And engagement is in the full sense of that word. It's not just a piece of paper handed to the patient saying, this is your care plan. It's being involved, understanding their care and knowing what they're meant to do in the next year to keep themselves healthy. Risk stratification, we've heard a bit about that today from both the Minister and the opposition about, well, we need to think about who we're treating and what level of investment we're making, and we need to think about the level of acuity of the people in front of us. Even talking to colleagues in the outside over lunch, we are spending a lot of money on people with fairly low risks, and we need to redirect those funds to those people who need to have that spend. So I think one of the themes that we'll have is the right doctor doing the right thing with the right team at the right time is the sort of mantra we want to say our outcomes should deliver. Clearly the care plans and team care arrangements, we're convinced at the AMA, and I know from working with you, that a structured approach to chronic disease management is actually is likely to deliver a better outcome. And we've got things like the diabetes trial that we want to analyse, what worked, what didn't work. Catherine King today talked about the Veteran CVC program. What are the elements of that worked? What hasn't worked? How can we refine it? We do want systems that continuously improve. And again, it's a little bit about that measure and share. High quality systems do actually understand their outputs, they understand what they're doing. I just thought, just to remind you of something that the AMA developed a little while ago, and it's still on our website, our own policy on chronic disease care, effective care coordination, the dot point underneath that is that care that is led by the patient's usual GP and based on clinical need. Actively involving the patient in goal setting and decision making, enabling patients to better understand and manage their condition, funding that follows the patient through the Medicare system that supports the provision of GP of initial and ongoing care, funding that supports the coordination and transition of patient care between health providers and across healthcare and community sectors. So we've done some work already. That work will certainly come before the committee, and that's the sort of thing I want to hear and want to analyse and get my committee to make recommendations on. So look, I'm really pleased to be here. Thank you very much for your invitation. I'll be all ears this morning, and certainly our committee is a consultative one. We'll have public consultations. We'll actually speak directly to the AMA to try and make sure that we get your views and we can collect them all together. Thank you, ladies and gentlemen. I'm looking forward to this session.
Thank you, Dr. Hamilton. With us today also is Dr. Tim Ross, a general practitioner with more than 15 years' experience in urban, rural and international from the UK general experience. Tim now combines clinical work with his role as National Medical Director with Bupa, where he works across the Bupa businesses to provide clinical direction and strategy. He is also the clinical lead on Bupa's GP pilot. Tim will lay the groundwork for us today by talking how the new generation of GPs are looking to practice and the changing face of general practice. Would you join me in welcoming Dr. Tim Ross?
Thank you, Brian. I have to admit, when I was rung to come and do this talk, I did have to ask the question, in what capacity am I doing this talk? Because I do have dual roles as a general practitioner and as an employee of Bupa. And the remark was made, we want your opinion as an individual, as a young GP. And I said, that's very flattering of you, but I have done 17 years of general practice, and you might find I'm more mid-career. And the response from Secretariat, well, compared to the membership, so maybe that's a small take-home message to get some younger GPs involved in the organisation. But the context I want to give is mainly my personal context. I certainly come here with Bupa on my shoulder, and I'm very proud to work for Bupa. It's a fantastic organisation, and the opportunities there for the profession to have input to in the evolution of private companies helping with healthcare in the future, I think is huge. So I've got one Bupa slide at the end, but a lot of this is what I'm bringing to Bupa when I work there. So, not that one. There we go. Oh, so now it's going to, yes, same thing as Steve. My cohort, I actually graduated in 95, so I was the first member of the provider number generation. So it's 20 years since I graduated, so it's 20 years since it's been compulsory for everyone to do postgraduate training for general practice. There's been an increasingly female workforce with that. But it's not just the females in the workforce, it's the males as well, and I count myself among them, in that we have a desire to not work full-time, not work 5 days a week. We look for increased flexibility in our working arrangements. A lot of my cohort have not bought into businesses, but that's not a comprehensive rule. There are some very entrepreneurial, business-minded younger GPs who are setting up some fantastic clinics. But compared to the norm of people having a view and buying into a clinic, that's certainly no longer the case and hasn't been for some time. I will say it in later slides, but the change in medicine has made general practice a very heavy clinical responsibility, and it's a fairly intense job to do. So a lot of people look for other things to do throughout their career. The difference in technology, medical knowledge, pharmaceuticals, it's a very different career now to someone who entered it in the 60s or 70s. I must have to point that somewhere. Does that one work? Slides are not wanting to move. Here we go. I think I've gone forward a bit there. Where are we? It's a good place to point this to. Okay. So just looking at our current funding models, it's a fee-for-service model. We all know that. It's a model where the government pays a moiety to the patient for a GP spending time face-to-face with a patient, and that's a fairly transactional business model. It's fairly simplistic, it's fairly old, and it's activity-based. And activity has to be recognised, but having the model purely that way has its limitations. And it's actually the most expensive point in primary care. Primary care is the cheapest part of the health system, but we fund it at the most expensive point, a face-to-face consultation between a GP and a patient. We do have our blended payments that have come across, but I see all these as sort of add-ons, and certainly when you look at the core income of patients, it still comes from the item numbers from their fee-for-service care. The big hole I see in current care is we have a hospital system that was set up in the 1800s to treat things like acute infections, babies and war injuries, and that's evolved somewhat since then. And then you have primary care, and I always love the fact that we're fighting pharmacists at the moment, which I think for very good reason, because I think they're the least clinically trained of anyone who does a health degree. But the irony that general practice came out of the apothecaries in the 1700s and 1800s shows we've really gone full circle, and they're trying to do it all over again, which doesn't make much sense to me. I think community care is the black hole, and a lot of the work I do at Bupa looks at this space. How do we upskill the teams that GPs will hopefully lead in the future to provide greater community care for patients in their homes, in their communities and in their primary care centres that keeps them out of the hospitals? How do we increase that literacy of our patients and provide access and equity? None of the current funding looks at this and supports this. So in the future, I see team and community-based care that's GP-led, so you have the right person in the right place at the right time. I think we spend a lot of time defending our profession against nibblings from allied health professionals and pharmacists. I think we have to go beyond that and have real courage and show leadership in reshaping the system, and I think it's fantastic that we'll be leading this primary care reform committee, but I think it's up to the college and the AMA CGP for us to actually lead and take ownership of what's important to us and actually be prepared to delegate. Having worked in the NHS for a year, I would never want that system to be taken and planted here, but the effect of the team care where patients could come and just see the appropriate professional and not even necessarily the GP was a far better use of everyone's time and clinical expertise. And I think if we can find the right funding model for that, we need to be willing to say that it's much better that a physio or a psychologist or a dietitian is doing that work, and you don't have to see a GP just to allow the funding to occur. I think at the moment there's huge threats to primary care in that we're not attracting new graduates. People are wanting to go and specialise, and if we really want primary care, it's something the universities have to look at, and it's something the profession has to look at. How do we make primary care attractive to graduates such that they are going to want to come and work in general practice? A lot of people talk about quality-based outcomes and rewarding quality. I'm a big believer in evidence-based medicine, but interestingly, the QOF, the quality outcomes framework in the UK has been going for 10 years now there. I had the privilege of working there in the first year of it in 2004, known as the golden year, and all my mates who are still GPs said they all have great cars but they're 10 years old. But interestingly, a group from Monash University here, there was an editorial in the BMJ, they did a study on the health outcomes since the QOF was introduced 10 years ago, and still the one single measure that demonstrates the health of a community is the social determinants. So it doesn't matter how good your care is, it's your engagement with the community services, schools, local councils, emergency services, and actually getting that health literacy and inequities ruled out. That's what will actually make the difference to care. So what do I see in the future? Well, the governments are seeking certainty around these rising health budgets. So I think we have to look at a population and health profile. If you look in New Zealand, the way they fund their model, it's based on populations and health. So therefore, you've got to not be scared of the C word. Capitation does not necessarily mean that's the only funding model. The use of medical home, I think, is a gentler introduction, patient voluntary registration, patient registration. I think down the road, the government will come to the point where capitation is really their only option, and I think our formation of funding models around that, so that capitation is a part of the funding model, not the funding model, is where we can protect our own interests. I'm very firm on financial and clinical independence of practitioners. Working for a private health firm, a lot of people worry about managed care and being ordered what you can and cannot do. But we only have to look at the lack of Medicare rebate rise in the last 30 years and the loss of income potential in any way for general practitioners in the UK for them to be dire warnings to ever trust government funding on its own. So I think my generation and all of us here in the room would agree that we never want to be reliant on that. So I look at equality and social integration balanced with activity. I think we need to be rewarded for the work we do, but we need to do it in a more sophisticated manner, which I think there's already discussion here as Steve opened up on some of his slides. So I see there being blended or block payments in the future. So there'll be bundled payments for the government for looking after certain disease profiles or certain populations. But I also see that we should maintain a fee for service for the work done. So where we're doing work as a GP, depending on whether it's a phone interaction, an email, a face-to-face consultation, there's a million different ways we can provide care, and we can work out the funding around that works much better for us all. We're looking in Bupa certainly at the telehealth, so there's a lot of technologies coming out. We all wear our Fitbits and we have our fitness monitoring, but there's far more home monitoring devices that you can have people with chronic diseases who can be monitored, blood pressure, blood glucose, O2 sats, the works, and you can have that all being fed into your clinic. You can manage them from the clinic remotely. You can send people into the home to care for them that way, and even be going in there managing IV antibiotics and things that might otherwise put them in hospitals. And I also think we need to financially recognise that if we're a primary care centre engages with the community. At the moment, the patients come to us for our services. There's not a lot of outreach. There's some fantastic programs going around with some GPs who do engage with schools and communities and provide group work with people for chronic disease, but that needs to become the norm rather than the exception. I admit no system's perfect, and I'm not trying to propose a model. I'm just proposing some ideals that I think we could possibly follow. Certainly, we would love to have the world's best health system at a cheap cost, but that doesn't work given the cost of technology. And nothing's going to suit everybody, but we have to have a go at it, and I think now's as good a time as any with the reviews going on. So this young GP's wish list, the reference there is in part when I was about 15 years ago starting out in general practice, I found out from one of the mums that when they would, in the mothers group, they'd say, which GP did you see today? And they'd say Doogie, because I looked about 16. But I'd also like to pay tribute to the WA president, Michael Gannon, whose nickname is also Doogie. One, because back in Amsterdam he did look young, but he still has a bit of a Doogie resemblance still.
Does he sing though?
Yeah. So my future, I see team-based care where we have large primary care centres with lots of different disciplines working together, being led by GPs who are sharing technology so that a patient system is shared by everyone there. You have diagnostics, you have pharmacy on board, and that practice is supported. So people may want to have ownership. They may prefer to work for a company that owns practices. But I understand the hesitations around that. There really needs to be recognition of evidence-based practice. A lot of we GPs do a medical degree, we do our fellowship, and then we choose what CPD. But it's only the really advanced, and I think the teaching practices do it a lot, where you sit down as a small group and say, why do we keep treating, or why do I treat a patient in this way, rather than just doing one-to-one behind closed doors all the time. And I think that evidence-based will be a way to further the best care. And having those other career options, be it in any of those areas. So just very quickly to touch on the Bupa model, we're beginning to open, we've opened one GP clinic in Sydney, which is fairly traditional, but our aim is to make big primary care centres. I had a big chat with Liz Miles when she was president of the RACGP, and we're actually looking to open quality-based practices that support GPs to do the work they want to do and encourage multidisciplinary care. So Liz Miles sort of said, sort of like the anti-corporate. And I said, well, that's flattering of you, given the reputation of some of the corporates out there. But it is what we want to do. We want to have partnerships with universities in terms of researching and teaching as core, and that's not just of medical students and GP registrars, but of any of the other disciplines working in the practice. But you really have a one-stop shop that patients can come to when they need to, but has the outreach ability to look after people in their home and in the community settings such that they don't need to go to hospital as much as they do, where it ends up taking time and a lot of money. Bupa is a very progressive model in terms of looking after its staff, and certainly working for Bupa, we've got a number of health services businesses which sit outside of our health insurance arm, and so there'll be really good opportunities for clinical staff coming to work at Bupa, be that in our GP clinics. We also do health assessments for medical visa services, and we have GPs in our care homes as well now. So there's a career path opening up in Bupa as we increase our clinical offering. So that's just a few concepts I wanted to throw out there as a comparatively younger GP. I see a bright future for primary care. I think we're the next big thing in healthcare. We're going to be what saves the system before it falls over. And thank you for listening.
Thank you, Dr. Ross. I guess not all corporates are the bogey. I'd like to introduce to you Dr. Bartoni. Tony Bartoni is the current president of AMA Victoria. Tony has been chair of AMA Victoria's section of general practice and is serving member of both the AMA board, Federal Council, AMA Council of General Practice and its executive. Tony will be discussing the achievements of our health system under fee-for-service and why it should continue to play a fundamental role in the funding of Australia's healthcare system. Would you welcome Tony Bartoni?
Thank you, everyone. It's a privilege to be here today to, I suppose, argue for the incumbency of the system that we've got, and hopefully we'll share some salient points with you. But before I start, I want to thank the Secretariat, especially Michelle Grabatis, who assisted me in the preparation of today's presentation. So in today's presentation, I would like to look at the Australian healthcare system, and given that it's first rate and world class, and how this was achieved under a fee-for-service environment, and then briefly look at maybe some of the alternative systems and some of their shortcomings, and then come back to why the fee-for-service model should remain the cornerstone of our system. So Australia does have a very exceptionally good healthcare system, and one that we should be proud of. And whatever measure or metric that we use or look at, or whatever report we choose to find, it's one of the most efficient and highly performing health systems in the world. The OECD, in fact, says that it's one of the best, and we can look at a number of measures. Let's look at life expectancy. At the moment in Australia at birth, it's 82 years. And if you look at for women, it's 84 years, and for men, that's 80 years. And that compares favourably with the OECD comparisons of a gender gap, which is nearly as much as 6 years and much less. Death rates. mortality rates continue to fall, and if you look at the COAG Reform Council report, it says that they've fallen nearly 8.4% in the years 2007 to 2012. And if you look at infant mortality, the rate currently in OECD countries is 4, and in Australia that's 3.3. We look at surveys carried out. Australians rate their health as good, and that compares favourably with OECD averages, ranking them 4th in the world. So whatever, there's a lot of numbers there, but whatever numbers you look at, it serves to underpin that the strength of the Australian healthcare system, and that it's underpinned by the quality of its general practice and the pivotal role of its GPs in that system. We know that GPs are the first point of call for when Australians feel unwell, and they manage up to 90% of the problems they're confronted with on that encounter. So if we then look at, efficiency and cost, it's a pretty cheap spend on general practice when you look at the numbers. Only 7% of the total health spend goes into general practice, and the Commonwealth spend is only 5.6% of its total expenditure on health. Even the Productivity Commission report on government services in 2015 said much the same thing, that general practice still remains a modest cost to the Commonwealth Government. A cost which was only $7.3 billion in 2013-14 on fee-for-service in general practice. Let's look at it another way. If you look at age standardised expenditure on general practice per person in 2013-2014, big number, big word, but it was $299. You compare that with the real recurrent expenditure in public hospitals by government of some $1,819 per person. You can see the efficiency. If you look at National Health Performance Authority data, it said that in 2012-13, 84.7% of Australians visited a GP at least once that year. The same Productivity Commission report shows that when it comes to access and affordability, only 4.9% of Australians rated that said that they would either defer or not attend a GP because of cost in that year. If you look at Beach data, it basically highlights that as GPs, the cost is, the GPs in the health system, the cost would be more if they were provided in a different setting. So basically, if you were to provide the same general practice service in an emergency department, that same service, which would be the cost of a standard consultation in a hospital ED, would be anywhere between $399 to $599. The same Beach report says that basically, GPs are doing more than ever keeping Australians healthy. And, you just need to look at the numbers again. 68 million extra problems dealt with, 24 million of which were chronic conditions such as diabetes and depression, up some 48%. There were 35 million extra GP encounters, up some 36%. 17 million of these patients were over the age of 65. Even that was up 67%. There were 10 million extra hours of GP clinical time, up some 43%, and also 10 million extra procedural treatments, again up some 66%. All this serves to say that GPs are currently dealing with more problems per encounter, and they are providing patients with greater access to care. The OECD data also underpins that basically Australian GPs are managing problems such as diabetes in the community better than the OECD comparisons. If you look at hospital admission rates per 100,000 of the population, in Australia it's 6.9 per 100,000. You compare that with Canada at 15.8, or UK at 22.8, or worse still, Sweden at 53.8 and Germany at 55.5. So we know that general practice is the home of healthcare, and I've said that already, that 84% of or more of Australians have visited a GP once in that year, 2012-13. A survey by Menzies New revealed that 93% of patients return to the same practice, and 66% of patients are the same GP. These strong retention numbers are no accident, and maybe explain why general practice in Australia is so efficient and effective, offering access to the Australian population from everything from preventative health care and acute care, right through diagnostic services and treatments and disease management, and, when necessary, referral to specialists, and offering a range of allied healthcare services, often sometimes in-house, and of course, at the end of life, palliative care. A National Health Performance Authority report on GP attendances show that overall Australians see a GP 5.6 times a year. However, more than a third of the population visited a GP 6 times or more in 2012-13, and 1 in 10, nearly 12.5%, went to a GP 12 times or more that year. However, we know that those who are seeing a GP frequently are generally very unwell, and when you compare rates of consultations with GPs and specialists with other countries, it's clear to see that we're very close to the OECD average. So, all this holistic patient care has been achieved under a fee-for-service environment. Many naysayers will say that fee-for-service doesn't provide for a quality service or a professional service, but I think those numbers that we've just gone through serve to at least underline the quality of the system that we've got. And it shouldn't be a surprise, because basically, if in a fee-for-service environment, if the patient doesn't value your service or doesn't think much of you, they're not going to pay for it. I think increasingly, though, we need to understand that the principles of fee-for-service in our system are now being eroded through inadequate Medicare indexation and competitive discounting, which is now replacing a fair and reasonable fee-for-service. And there's an increasing expectation now in the community that of a no out-of-pocket cost of care, and that surely is what the issue is all about. So, fee-for-service, I believe, has earned its place to remain central to our health system. It's fundamental, and the key words about fee-for-service is autonomy and choice. It gives the patient the freedom to choose their care provider and the services that they are best suited for them and their needs and their situation. They can choose when and where they will access the care they need, and it ensures that the funding will follow the patient. And services are only paid for when used for by that patient. But more importantly, I believe it preserves the tenet of the doctor-patient relationship. It's all about a trusted relationship, and that is fundamental to the care provider and the receiver. Furthermore, I think it also ensures that patient care, the care is patient-centred, and that's what it's got to be all about. And a doctor's primary duty, we know, must always be to the patient, and it ensures that the patient can trust their doctor's recommendation and knowing that their doctor is not influenced by anything else. Fee-for-service ensures that patient care is not rationed and that patients don't miss out because the budget for that service has been used up. Patients don't miss out because the service is already fully subscribed. It could be many of these issues that people use to criticise fee-for-service. But I think it's actually got to do more about the failure of the government to adequately fund support to patients as opposed to problems with the funding model itself. So, is there anything better out there? All the other systems clearly have their own weaknesses. If you look at capitated payments, they're estimated on the basis of historical data. Bundled payments gives you the opportunity for cherry picking and picking those patients that are less complex. And it also shifts the financial cost onto the provider. And salaried models just completely disencourage any innovation. If you look at capitated and bundled models, they also compromise patient care, and more importantly, I believe, it also compromises the doctor-patient relationship. They can restrict patient choice, and they can also be a hell of an administrative burden. Some countries also want to use a combination of pay for performance in combination with some other with fee-for-service models, but I think that can then lead to chasing targets rather than attention to the patient, and that's clearly not in the interest of the patient. So let's look at some research and evidence. If you can do a Cochrane review of all the available literature out there looking at fee-for-service, most of the literature reports that it's an effective way of driving professional behaviour. And also, despite the fact that it may be associated with more patient visits, it's associated with greater continuity of care, with a higher compliance in terms of number of visits, and more importantly, early intervention. And surely in a preventative healthcare system, that must be crucial. There's no conclusive evidence when you research the literature that there's any alternative payment model which is superior to fee-for-service. Other models from around the world may not translate well into the Australian environment because of the Australian culture of predilection to only paying for services that they use. And also parliamentary research into this area has shown that previous attempts to introduce alternatives to fee-for-service have failed. And that shouldn't be a surprise to us, given how entrenched fee-for-service is in our system. Previous speakers have sort of looked at the issue about that fee-for-service may not be the perfect system, but that doesn't mean we have to abandon it, especially a model which has really served us well to date and really served us with some excellent health outcomes when we compare it with the rest of the world. General practice has proven its value as being the most efficient and cost-effective in the health sector. It has delivered comprehensive and quality care, it can coordinate care, and it can ensure that services are available for patients and accessible for patients who need that additional support. Fee-for-service may not assist in the delivery, where fee-for-service doesn't assist in the delivery of those aims, then alternative funding mechanisms may be and may have a role as an adjunct, and that's what we need to look at in the discussion today. Just to tidy up, we've already heard about the National Health and Hospital Reform Commission's recommendations, and they were that fee-for-service be supplemented with additional sources of funding, but only to support multidisciplinary clinical services and coordination. Other funding mechanisms should be utilised where appropriate to supplement but not erode the good work of general practice. And therefore I believe fee-for-service should remain the cornerstone of general practice funding. Thank you.
Thanks, Tony. There's some questions coming through already. Please put your questions online so that we can follow with the question and answer after our next speaker, Dr. Tony Lemke, who is a former General Practitioner of the Year, Clinical Director of the Australian Primary Care Collaborative, and Executive Director of both the Australian Centre for the Medical Home and the Person-Centred Care Collaboration. Tony will be rounding out the discussion by talking about how a mixed model of funding could better enable systematic and proactive team-based care with a focus on prevention and improving health outcomes. Welcome, Tony Lemke.
Thank you, Brian, and thank you very much, Secretariat and Brian, for asking me to be on the panel. Brian, you left out my main qualification. I was the Sydney University Medical Society Donkey Kong champion in 1983, and that's of relevance later. As you see, look, I'm from the Northern Rivers in New South Wales, home of the Big Prawn. That's in Ballina. I drove past that this morning. Austenville's just up the, as you all know, Austenville's just up the hill from the Big Prawn. We've got our own big thing to our devoted to our major demographic in town, the Giant Walking Frame. And if you go down Main Street, Austenville, under the Giant Walking Frame, you'll come to the Austenville Clinic, where the place that my home of joy and bliss. So I've worked at the Austenville Clinic for 20-something years. I'm a principal. I've been a partner there for that time. We're a private billing general practice in rural New South Wales, and I work there with my partners. There are four of us as the partners in the practice. My partners and I aspire to provide the highest quality care that we can for the community of Austinville. We want to look after our patients as well as we can. And our patients need and want that sort of care. They want the highest quality care that they can receive, and that looks like one of our patients, but that's not. That's actually my mother, and I put that up there because she's 90 on next Thursday morning. So I'll go down and see her in Sydney. Get rid of Marcus Welby here. There we go. Back one. That's not one of my patients either, but Susan Lee is a funder, and it is clear to us that the funders, in our conversations with the Minister and both parties, the funders are looking to fund quality practice and to stop funding low-value care. That's the challenge. Now, what sort of care do our patients need? What does it look like? The evidence is known and proven that patients and their families benefit from an ongoing relationship with a particular general practitioner over time, where that practitioner is supported by a practice team of other general practitioners, practice nurses and other clinical staff, and the rest of the health system wraps around that relationship, wraps around that partnership to deliver care. Known and proven evidence. When we map that out for our federal and state government departments, we can say that the real work in healthcare happens in the patient's home and happens between the patients and their families. The next layer of the health circle is the general practitioner and the general practice team, and that's the medical home. Now, the medical home is a term that has general practice that has some particular characteristics. The medical home is the general practice that a patient chooses to be accountable for their ongoing care. And in a medical home, that care is patient-centred, comprehensive, coordinated, accessible to the patient, and has a focus on safety and quality. That's the international characteristics or key points that make up a person-centred medical home. And in Australia, all medical homes are general practices, not community health centres, Mrs. King. All medical homes are general practices. Not all general practices, however, are functioning as fully featured medical homes, but all medical homes are general practices. And wrapping around that relationship, that important relationship, is the community care with our specialist colleagues, allied health professionals, pharmacy, organisations such as Meals on Wheels and Hospital in the Home, and then the secondary health sector wrap around that relationship. And as part of this person-centred health system, if everybody is performing at their full potential, at their peak capacity, at the higher level of their skill sets, patients don't drift out to where they're not to outer layers of the circle where they shouldn't be. So if care at the home is good, patients don't end up in hospital. If care in general practice is performed at the highest level of skill set, they don't end up in specialist care. Specialist consultants can act as consultants and not looking after things. Consultants should look after things that are of significant rarity or require special skill sets, but not common things. We should be freeing up our health service for those who need it. And hospitals should not be looking after people who should be looked after in the home. So if our doctors want it, and our patients want high quality care, and our funders want high quality care, what's the roadblock? Now, I agree with Tony. Australia does provide, to a large extent, very, very high quality care, thank goodness. But there are roadblocks that I see in my practice. For example, as I said, we're a private billing practice, $75 to see us. We discount you if you have a healthcare card, we discount you if you've got a pension card. We end up discounting people who we see a lot, who are very disadvantaged, who are underprivileged, who have significant recurrent illnesses within their family, who have dementia, who with palliative care, who are very aged, who lived in nursing home. We tend to bulk bill a lot of people. I'm sure many of your practices end up in that position. Private billing practices that end up discounting more than half of your consultations. That means that the more I look after disadvantaged people complex people, sick people, the more I visit people in nursing homes, the more I go into the hospital to visit people, my patients who are hospitalised, we go and visit them in hospital. The more I look at the systems in my practice and try and improve them, the more time I spent training students and medical registrars, the more I seek quality in my practice, the less my income is. The less my income is. The more I pursue quality, the more disadvantaged people that I see, my income goes down. So that's a bizarre sort of system, a bizarre sort of incentive. So there's a tension then. There's a tension then between general practitioners, professionals and our professional ethics and the commercial realities of running a business. There's a real tension there. Luckily, as general practitioners, we're professionals. The model of medicine as business, as patients and consumers, leads to a business model based on patients as numbers. You lose loss of professional ethics sometimes. There's risks in that model, and we see that out of control in the USA in many places. So I can take you to 1,000 medical homes in Australia. I've worked with the collaboratives. I can take you to the addresses of 1,000 practices that are acting in medical homes, high professional ethics, seeking quality, and therefore taking a hit in their income in the pursuit of quality practice. And there's another tension between what we get out of high quality general practice and the value it has to the community in keeping people well and out of hospital. And that was reflected. I had a chat down in Melbourne last year at a conference with Doug Eby. It's Doug Eby and Dale Ford. Doug Eby is the director of the Alaskan South Central Foundation, Alaskan Health Service, looks after the Alaskan Natives. He went to Alaska 20 years ago as a medical director, realised the health service was failing, disrupted the entire system and rebuilt it. They're consistently recognised as the most effective, efficient, low-cost but high-quality healthcare system in the United States. And he told us that he was able to halve his costs in secondary care and halve his costs in hospital by doubling his investment in primary care. And it was enormous value to their health system, both in terms of cost and quality. And it's reflected with the recent changes that were announced by the government. We did a calculation that it is cheaper for the system, for a patient, to see their general practitioner in Australia every week for a whole year, than it is for them to spend one day in hospital. Every week for a year is cheaper than one day in a public hospital for the system. And yet, we had a proposal to make it harder for people to go and see their general practitioners. You work that out. So there's Don Berwick from the IHI likes this analogy. There's a bridge, you may have heard of this bridge, it's in Honduras, and it goes over the Xolotiki River, a fine bridge, fit for purpose, a very strong bridge, proven to be strong by Hurricane Mitch. 150 bridges were washed away in Honduras, but the bridge over the Xolotiki River survived Hurricane Mitch. However, the river moved. So they're left with a fine, strong bridge that didn't get them to anywhere near where they wanted to go, Hurricane Mitch. So that's, to some degree, we've got a fine health system that to extent is not getting us to where we want to go. So let's look at how general practice can be funded, and we've discussed some of these issues. Fee for service for general practitioners is the cornerstone of the way I'm funded at work, and I'm happy about that. It has disadvantages. I wasn't going to go through them, but some of the disadvantages, the funding doesn't follow the patient, it funds the providers, so that if you live in Double Bay, you get the fee for services per patient is much higher than if you live where I am, which is much higher than if you live in Brewarrina, because there aren't the practitioners to provide the services. It doesn't do well for disadvantaged communities. It doesn't do well for people with mental health conditions. There are disadvantages with fee for service, but it is like my daughter we went to local council yesterday, and my daughter was despairing about democracy watching local council, and I told her what Winston Churchill said, which is democracy is the worst system of government that there is apart from all the others. And I would agree that fee for service is the best. Other aspects of fee for service would be fee for service for members of a medical home team or a general practice team. I think that was having the nurses able to do wound dressings and immunisation without me going in and waving hello to the patient was marvellous. It reflected their autonomy and skills in that level, and that was taken away. Being able to employ a clinical pharmacist in my practice to assist the AMA position yesterday would be fantastic. Fee for service for members of the general practice team would be excellent, and we see very little of that. Patient enrolment. Medical homes, the practice that a patient chooses to be responsible for their ongoing care. Knowing who your people are and what they've got is a tremendous advantage if you're trying to do population health, if you're trying to lift your screening rates, your immunisation rates, find the gaps in your services, who aren't you seeing that you need to be seen. And it also can assist with the equity issue. You can load patient enrolment for rurality, aboriginality, chronicity, age, to reflect the fact that some practices are working harder with a harder population, sacrificing fast turnover for a more complex condition, and capitation or enrolment, patient enrolment can deal with some of those issues. Chronic disease funding can be bundled much neater than it is with the EPC system at the moment, such that a bundle of care for particular chronic diseases that allow you to be proactive and systematic in the way that you manage them, and enable to use the appropriate person in your team to provide the care, and allow you to use other modalities for treating them. The nominated patients, not on the NBS. My mother, who's 90, is a veteran. She has a gold card, fantastic, so she can be on the CVC program, which enables her to receive, her practice receives funding for non-NBS reimbursed care, practice nurses visiting her home, extra contacts. I would love to buy some of Bupa's patients, or buy some of Bupa's patients from them. For significant fee, I could keep them better and well and out of hospital using my practice nurses and my practice needs. I'd love to buy some of the frequent flyers who attend the local hospital to give them better care. That's a different way of looking at funding. And then it comes to quality improvement payments, which is what I wanted to move to. These are challenging, they're somewhat tricky, but very important. So quality payments include things like the PIP for doing after-hours care, the PIP for having a practice nurse, the PIP for doing e-health. Improvement payments is different from pay for performance payments. I'm going to talk about that. I was Sydney Uni Donkey Kong champion. Before that, back in the old days, I was pretty good at Circus Charlie as well. And Circus Charlie is this game. Some of you may remember playing it. So in Circus Charlie, what does this sound? Nearly there, let's go. You make the end, jump through all the hoops, showered with praise, showered with money. So the key point about this is that funding for quality, funding for achievement, funding for outcomes doesn't have to mean jumping through hoops that you don't want to jump through. I spent a fortune learning to play Circus Charlie. No one made me do it, but it was where I wanted to be. If I can get funded, not to jump through hoops, but to get to the improvements that I want to get on behalf of my patient, funded for improvement, then that's of real value to me, because at the moment I wear that. If I want to deliver better care, look at my systems, employ more nurses, provide better care, I wear that. I would love to be funded to improve. And there's an important distinction in improvement theory about funding for quality or quality payments. Duran's trilogy, quality improvement, quality control, quality planning. I'll show what that means. Quality control is what we think of when we think of quality payments, the QOF. You need to do this, you need to reach that level, or this. It's lowest common denominator, defect identification stuff. Quality improvement, and furthermore, quality invention is working to improve the systems of care, working to improve the outcomes for our patients, working to make it easier for us to work in our practice, working to improve our practice bottom lines. That's the joy. The joy. And the collaborative practices learn the skills, the teams, the resource to do quality improvement and find it quite joyful to improve the care they provide for their patients. The quality control stuff, the accreditation stuff, the jumping from hoops stuff is crap. The quality improvement stuff, the joy is underinvested in. And I think that when we're refunding general practice, we want to fund general practitioners for their professionalism and their joy in improving their care, not treat them as businesses where we have to check on them all the time, fund them. It gets tricky, doesn't it? We'll learn out in Circus Charlie number 6, the hardest bit, because if we're going to identify how do we recognize, the greatest challenge for our profession at the moment is how do we recognise and support quality practice as opposed to other practices that is fair and equitable for the people providing it. And it's disruptive. It seems to me, and you may correct me if I'm wrong, and Steve may be able to come up with a bucket of gold, but I don't think we're going to get paid more for doing the same thing that we're doing now. Neither side of the politics has given me the impression they're willing to put the fortune into primary care. They should, the evidence is it would improve outcomes. It doesn't seem to me that they are. If we're going to recognise and support quality practices, some practices will have a business model that's not built on quality that will be losers. And other practices who have developed good systems providing quality of care, who've engaged with their patients, who are using data-led improvement strategies, will be winners. But it's going to be disruptive. It's going to be disruptive. And the college paper was good. The college paper about funding general practice was good. It said we should get blended payments, we should get quality payments, we should get capitation payments. But it didn't say what we were going to have to demonstrate we've done differently to get paid for that. It implied that there would be a bucket of money come on high because we're all such good blokes that they're going to give us money for doing quality stuff. How are we going to demonstrate our quality? What data are we going to have to provide? What are we going to have to do? Will be the other side of the equation. That's where it gets tricky. As a profession, how are we going to tell them? We're going to demonstrate to them that we're delivering the quality practice for our patients. Other practices who aren't doing that, can we align the professional incentives with the business incentives so it becomes a good business case to deliver quality, not attention, but good business to deliver quality? That's the challenge for us as a profession, as I see it. If we can, all right, and so this is, practice and demonstrate data-led improvement, and we need to resolve that tension between, we all want to deliver the best quality care, the tension is to make it the business case for that. That's what we need to pitch to the government, a business case that suits our practitioners who want to deliver quality care, our funders who want to pay for quality care, and our patients who desperately need to receive quality care. Thank you.
Thank you, Tony. I think the three papers presented have been food for thought. We do have time for questions, and after the Q&A, I'll call an end and we'll put up on the board the draft motion, and then there can be some discussion on that. The questions will not be up on the board, rather I will read them out, and I'll try and get through them all and direct them, some of them anyway, to the questioner's direction. The first one is fee-for-service exists in law, accountancy, financial consultancy. Why should it be any different? It's asked by Tom Stanley, and I'll ask anyone on the panel to answer it who would like to. Do you want me to read it out again? Tom Stanley asks, fee-for-service exists in law, accountancy, financial consultancy. Why should we be any different?
Bloody hell, I don't want to do... I'm quite happy not to be associated with accountants, lawyers, and so there is... A fee-for-service is part of general practice, it should remain part of general practice, but there is this access and equity issue. We consider ourselves special, which is why we ask governments to fund our quality improvement, why our fee structure is underpinned by government funding, why we're supported through all sorts of activities that we get, because we're special, because it's about health and everybody needs it. So everybody needs health. So it's because of equity, universality of access, the requirements of basic, it's considered a basic public right to receive good health.
Thank you. I'll move to the second question. I might direct that to Steve Hamilton. It's from another psychiatrist, Bill Pring. Would you agree that funding policy should be evidence-based? None of the information given us seems to show that fee-for-service medicine is less clinically or financially effective than capitation.
I absolutely think it should be evidence-based, and we heard from Tony to my left that when you look at the international literature and you examine different systems, there is no clear winner in terms of which system is best for outcomes. Tony also pointed out the good quality outcomes we have in this country, and we perform extraordinarily well. But we all know that there are places we can do better. And I think the AMA Council of General Practice would have us say, well, in certain areas we should examine other funding models. Are they going to do exactly what Tony just said to us? Can we align the business imperatives and the professional imperatives better? It doesn't mean we throw out fee for service, and I think as we're examining opportunities for the future, is there a way, in particular in my committee, to look at chronic and complex care to say if you do spend longer, if you think about it longer, if you spend some planning a bit longer, how do you reward that in a funding model that actually at the moment, the shorter you spend, the less you think and the less you talk, the more you get paid. So I agree with Tony, if it's a high quality practice taking time to improve its quality, how do you measure it? How does the patient know what they're getting? How engaged is the patient and what do the outcomes look like? And if it is indeed fee for service, what is it contingent on? What are the measurements that we have to make to prove that the quality is there? And maybe IT will help us, maybe there's something we need to do that's extra. If we add so much red tape that we can't do it, it's not going to work in this country. So I think we're I think the presentations today have been extraordinarily helpful in framing the sorts of things I'll be thinking about the next 6 months.
Thank you, Steve. There was a comment to follow that question. Chronic disease patients are not all the same. Not all of them require multidisciplinary teams. Many can be managed well by GPs alone or together with another specialist. The next question is from perhaps Harry Hemley from Northcote. Today in the Melbourne Herald Sun was an article indicating that Australia had the best cancer outcomes in the world because GPs refer patients to specialists for cancer care early. Would this be compromised by fund holding for the chronically ill?
Brian, I was impressed. So when you hear Kaiser Permanente talk, they have a whole of system approach to cancer screening. If you hurt your arm and go for an x-ray, they will know at your point of x-ray that you haven't had your bowel screening done and insist on you do it. They have systems of quality, systems of ensuring that there are no defects in their system that mean that people get the evidence-based preventative strategies that are required to keep them well. So Australia does very well. We could do better when we measure our performance in collaborative practices, the pap screening rates, their mammography rates, their bowel screening rates. Everyone thinks they're fantastic. When you measure it, you're not doing as well as you think. There's plenty of room for improvement.
Thanks. I'll direct this next one to the AMA President of Victoria. It's an AMA type question. Is true reform possible given the Pharmacy Guild have stitched up a deal to fragment primary care for the next 5 years? From Donald Rose in Tasmania.
Thanks, Donald, for that question, and it's an apt question. The Pharmacy Guild, their inroads or their attempts to fragment that care is quite clearly demonstrated in terms of the most recent community pharmacy agreement and the $600 million that's extra allocated in terms of medical services there. Now, we're reassured supposedly by the Minister that those services need to be evidence-based and they need to be proven, but the proof will be in the pudding. I feel that your point is well made, and it's a constant watch out and an area of concern.
Thanks, Tony. The next question I'll direct to Steve Hamilton again. GPs are being asked to do more and more for less and less. The government is planning to make the e-health record an opt-out process, intending for GPs to do a lot of extra work that will not immediately impact on patient care. GPs should refuse to actively work on the PCHR until the Medicare rebate freeze is lifted, so the medical profession sends a price signal to the government. Steve.
This sounds like a great AMA question for the AMA President. The electronic e-health in this country has, as we heard today, stalled for the last 2 years. The PCHR is a piece of e-health. I was on an international teleconference a couple of years ago when I went to Canada to talk about the health reform that we're putting together in this country. And the gentleman from Germany said, it's fantastic. In Australia, 95% of your GPs have got computers on their desk and you're computerised. Isn't that fantastic? And I said, well, hold on a second. Yes, we are computerised, but we can't talk to each other. What a tragedy. Over the last 10 years, and again, you know that I'm chairman of the National eHealth Transition Authority, and you know that the previous president worked very hard to get some standards put into that system. We have an individual health identifier in Australia. We have individual doctor identifiers. We actually have a systematic nomenclature. We can describe disease, agreed. We have an Australian medicines terminology. We have agreed communication protocols. I haven't talked about the PCHR. We have the ability to communicate better. On top of that, we built a PCHR. It's a bit quirky, it's not easy to use, it's not automatic, it's not in the background. Wouldn't it be great if you just turned it on, clicked a button and it just did things? And then you could look up any pathology, any radiology, any specialist letter, any discharge summary for the patient sitting in front of you. Can't do that today, but that's where we need to get to. Can't build that unless we can communicate. So AMA might do certain things to try to get some leverage. I mean, the AMA has demonstrated that you don't get things done if you don't talk to the AMA, and I think that's really important that we remember that. We advocate, and this is my AMA hat, for the whole profession, but we also advocate for the health system. And whatever action we take, we need to make sure it's for the benefit of the system, and what's the piece of leverage that we want to use. So I'd get my colleagues to consider that.
This next question is directed to Tim Ross. Not seeing the GP at entry point is the basis of misdiagnosis, is it not? We see it all the time in mental health. It is short-term, short-sighted, and a recipe for downgrading our profession.
Yeah, I agree with you totally. The GP is the entry point. But once you have a patient who is known to your clinic and you have a comprehensive history on the system, and as Steve says, we're bad at communicating with one another. If we've got technologies that enable that information to be shared, the GP knows that patient, the GP has worked that patient out, but that they're then working with the appropriate practitioners. That may not mean that they're seeing the GP every time they come to the clinic. But yeah, I agree with you totally. They are the entry point.
That was from Tom Stanley. This from Ross Kerridge. Would it be worth considering an additional fee-for-service item defined as supervising and coordinating a patient's healthcare, including maintaining a record of the patient's healthcare and services provided by any practitioner or health service, and providing information from that record as appropriate? Such an item or service to be remunerated on a monthly basis, providing that service for a month, with any patient only able to nominate one person at any one time to provide this service. This
Fantastic.
Could provide the benefits of old-style general practice, but actually fund it.
Look, I love that item number, and could someone please send that to me for my committee? Now, I'm not being facetious. You know, good quality care needs to be rewarded, and you know, we know what good quality care is. In fact, you know, as Tony said, if you spend time doing quality care, actually you get rewarded less. So if we're going to stay with fee-for-service, how can we use the fee-for-service to deliver the link between professional and financial outcomes? And it might be by better descriptors. Remember, the AMA Council of General Practice looked at the chronic disease item numbers, concluded that the current system isn't working very well, and started exploring options like, can we pay the right doctor doing the right thing rather than the beginning of the year, the end of the year, so that the opportunistic care plan doesn't get done, so that no one turns up at your practice like they did at mine with a care plan for their sunspots, for God's sake. You know, we need to think about what do our descriptors say. You know, what about the linkage with the patient? You know, and we don't want to make it too easy to switch. But on the other hand, we want to have a free ability for people to switch. When does the payment get paid? What do you have to demonstrate that you've done to get paid? It's along the lines of what we heard from Tony. What do you want to measure? How do we measure it? How do we make it easy to measure? And how do we fund it?
And Steve, that item number, Brian, is a bit like we do have voluntary patient enrolment for particular practice for our Aboriginal patients in the Closing the Gap program, and they can nominate. This is the practice I nominate to be responsible and accountable for my care for the next 12 months, and that's like an item number that says that this is my practice for 12 months, and in exchange for that, at the moment we have to do very little, which is a problem. I would think if in exchange for that we had to do some of those things, such as maintaining their record, uploading their shareholder summary, a payment for could demonstrate what we deliver for that, would be an example of how patient enrolment would work.
I'll shorten the next questions from Dr. Paul Neeskens. Patients want a primary relationship with a person. That person can be the leader of others, call it a team if you wish. A frequent complaint of patients in hospital, big multi-doctor clinics, is that they never saw the same doctor. Young doctors might want it, but what evidence is there that patients want team-based care? Tim.
I think it's about having the availability of the right practitioners. There's a sweet spot in general practice of having enough practitioners that you can cover one another when you need to, but not having so many practitioners that the patients end up being a number and they never see the same doctor. I think it's really valuable. Every clinic I've worked in, and even now, no doctor works a 5-day week. So if a patient comes in with an acute presentation, they might have to take their second pick doctor. And I think that's just something that the public recognises and we as a profession have to recognise. Different patients are going to need different things, but it's about having those enablers of a team working together. So whether or not someone needs to see a certain professional of whatever persuasion, that is all tied in, set up, ready to go for those who need it.
Another question for Dr. Ross. You highlighted blended models of care as the future. Given your strategic planning position with Bupa, how do you propose to ensure that privately insured patients do not take precedence over uninsured patients on the basis of ability to pay rather than clinical need, as was seen in the recent pilots with an alternatives insurer in Queensland? That's from Susan Doyle.
Yeah, I like that one because the Medibank trial in Queensland has failed. They've stopped it. I know Steve had some things that he's practiced with this, but our view was that it was always legally murky, and it appears that the murk got too deep and they pulled it. Bupa has 4 different businesses. So health insurance is one of our arms. We have our care homes where we look after the aged here and in New Zealand, and our 4th business is the health services business. So the health services businesses of dental, optical, GP clinics, telephone coaching and doing medical assessments for visa applicants are labelled Bupa, but they're actually not for health insurance members, or there's no advantage to being a health insurance member. They're open to all members of the public. Everyone's treated the same, and if you happen to hold Bupa insurance, that's good for you, but as we know, it has no applicability in the primary care space and we don't put any value on it.
It does drive you nuts though when you've got a patient you've looked after for years, you're doing health coaching, you practice nurses, seeing them regularly on a care plan, and all of a sudden one of the insurance companies has got the health coach ringing them regularly and fragmenting their care and sending them in to you to get tests done. That would be a much better investment by the health insurance companies in supporting general practice to provide extra care above and beyond which MBS funds, rather than setting up a standalone, unfragmented system beside it.
The last question directed to Tony Lemke again, from Steve Wilson. The more quality, the more chronic and complex and more disadvantaged patients' care I deliver, not only does my income go down, the less attractive my practice is to attract doctors. They won't come if they can go elsewhere, where the work is easier and the money is better. What solution do you have for that problem?
Steve, we live up the hill from Byron Bay, so you can work at Austinville and see the people who live under the giant walking frame, or down in Byron Bay and see all the Swedish backpackers with earaches and STDs, and make much more money. So, however, luckily, Steve, we've continually been able to find dedicated professional people who want to care for their community and belong to a community long term. But it is challenging. A lot of the registrars won't come to our practice because it's too hard, or they leave because there's too many sick people and go back to Byron Bay. So I think if funding would support quality, that would help us in our practice.
Yeah, indeed.
Thank you. Would you we now have to move on to the draft motion, if we could have that up on the screen. The motion is moved by Chris Moy and seconded by John Galotta. That National Conference recommends that the AMA contribute to the primary care review, recognising the complexity of services required of GPs in preventing, diagnosing and managing complex and chronic illnesses. acknowledging the fundamental and ongoing role of fee-for-service in the Australian healthcare system, and emphasising that where other funding models are considered, they must complement existing fee-for-service arrangements and focus on supporting the provision of comprehensive patient care by a patient's usual GP. Chris, do you wish to talk to it now? Could we have a microphone in the centre, please, so that anyone who wishes to speak to it can be heard?
Just listening to the speakers today, I realise that it's a very complex area, and while I listen to Tony and I completely agree, fee-for-service is very easy and simple, but there are issues because people do abuse the system, and the reality is you know, there are models of care out there who use fee-for-service which do not provide quality care. The flip side is I listen to these other models of care which are capitation and fund holding and all these sort of things, which really are so far away from something that can be understood from a grassroots GP that I find it very difficult from my point of view to see how it really works. I think we really need to be there to protect grassroots GPs, to be realistic and protect them, and also to be articulate these, whatever model that's decided upon, and that so that they can actually be implemented in a way which will actually benefit GPs but also the patients that are out there. So I think we really need to be there. This is a chance to do this, and if we're not there, I think we'll miss an opportunity to do something good but also fail our members.
Thank you. Chris, do you wish to talk?
Thanks, Brian. I think Chris has summarised it. As Stephen said, if you don't get things done, you don't get things done if you don't talk to the AMA. So I think the AMA has to be involved in this process. And the important thing about this motion is that we're not substituting fee-for-service. Whatever is discussed as future proposals will be in addition to and complementing the current fee-for-service model. So I commend the motion to you. I think it is an important time for general practice. There's a lot of changes. We've got an ageing population with chronic disease, so it's very important that we get this through and hopefully restructure the funding for general practice. Thank you.
Thanks, John. I'll open it to the floor if anyone wishes to comment.
Thank you, Brian. Gerald Siegel. I've been around long enough here. We've been, as an AMA, badly burnt by the RVS, spent ages on it, got nowhere. When we thought we were going to get something, it got dumped. I can't see that this is going to do anything other than ration services, ration money. So I want to know, the question is, what does the word contribute mean?
Thank you. No more speakers after the one standing, thanks. We don't have time.
Thank you, Brian. Two comments. One is, I think there's two types of fee-for-service, bulk billed and patient pays. I think we have to accept that they are two types of fee-for-service payment, and that's the elephant in the room, I think. The second comment is that if I had my chance to amend that motion, I'd say where other funding models are considered, they must be evidence-based and complement existing fee-for-service arrangements. The point there is that 3 or 4 years ago, Minister Roxon was about to block fund chronic disease money. At the last moment, that was quarantined to a fairly large diabetes project. That project has just been, its findings have just been published. We need to be aware of the evidence about block funding of chronic disease funding, and the data is there. Thank you.
Go ahead.
If I could just comment on that SMS Q&A thing, my two questions disappeared into the ether and were never heard, which some would say is a good thing, I know. Look, I think the motion is a good one. I'd add one bulleted point at the end in relation to, or a sub-bullet to emphasising that other funding models are considered, and would say that, and these must be subject to a no disadvantage test.
Thanks. So the 2 points from the last two speakers are well taken. We won't be amending the motion. It is as it stands, and it's a very open motion. And with Steve on the panel hearing those comments. Go ahead, Richard.
Thanks. I support the motion, but my cautionary observation is following the question I put to Minister Lee this morning, and that is that the primary funding problem is still there, and that is that the federal government doesn't want to subsidise savings in the state hospital system through the good work that we can do. So it's not interested in really increasing the investment in primary care and general practice. So we might be looking at some alternatives, but is the pie going to be any bigger? I don't think so.
Thank you. Chris, do you wish to the right of reply to any of those comments? You don't need to. Then I put the motion as up on the board. I won't read it again. All those in favour, please hold up your cards. Thank you. Any against? Do you wish that recorded, Gerald? Thank you. The motion is carried. Would you please join me in thanking the panel members for an excellent presentation.
Well, thank you, Brian and panellists, for an excellent session. And it's now afternoon tea time. At afternoon tea, could you please sign in for the AGM? This will take place after the Roll of Fellows item on your agenda. The sign-in is at the desks in the pre-function area. Only appointed delegates and members are to sign in and collect their orange voting cards and vote. Members and AMA staff are welcome to observe proceedings, but non-members, guests and other observers are not able to attend this session unless they're guests of the Roll of Fellows recipients. Thank you, everybody. Enjoy afternoon tea, and could you please be back at 3:45. Thank you.